Good morning, everyone. Today we will be discussing a very important topic in maternal health: hypertension during pregnancy, its diagnosis, and how we manage it to ensure the safety of both the mother and the baby. Hypertensive disorders are among the most common complications in pregnancy, affecting up to 10% of pregnancies worldwide. They significantly contribute to maternal and fetal morbidity and mortality. Hypertension in pregnancy includes four main categories: chronic hypertension, gestational hypertension, preeclampsia, eclampsia, and chronic hypertension with superimposed preeclampsia. Chronic hypertension: hypertension present before pregnancy or diagnosed before 20 weeks of gestation. Gestational hypertension: new onset hypertension after 20 weeks without proteinuria. Preeclampsia: new onset hypertension after 20 weeks plus proteinuria or signs of organ dysfunction. Eclampsia: preeclampsia with seizures. Superimposed preeclampsia: chronic hypertension complicated by new onset proteinuria or worsening blood pressure. Hypertension is diagnosed when systolic blood pressure is greater than or equal to 140 millimeters of mercury, or diastolic blood pressure is greater than or equal to 90 millimeters of mercury on two separate occasions, at least 4 hours apart. Preeclampsia is diagnosed by blood pressure criteria plus proteinuria greater than or equal to 300 milligrams per 24 hours, or a protein-creatinine ratio greater than or equal to 0.3, or a urine dipstick greater than or equal to +1 if quantitative methods are unavailable, or new onset of any of the following: thrombocytopenia, renal insufficiency, impaired liver function, pulmonary edema, or cerebral or visual disturbances. Risk factors include first pregnancy, age over 35 years, multiple gestation, obesity, pre-existing hypertension, diabetes or renal disease, and a family history of preeclampsia. Management depends on the severity and gestational age. For chronic and gestational hypertension, monitor closely blood pressure, fetal growth, and maternal symptoms. Antihypertensive therapy is advised if blood pressure is greater than or equal to 160 over 110 millimeters of mercury. The target blood pressure is between 120 to 160 over 80 to 105 millimeters of mercury. Medications considered safe in pregnancy include labetalol, nifedipine, extended release, and methyldopa. Avoid ACE inhibitors, ARBs, and direct renin inhibitors. Mild preeclampsia: monitor maternal and fetal well-being. Delivery at 37 weeks. Severe preeclampsia: hospitalization. Antihypertensive therapy, magnesium sulfate for seizure prophylaxis. Delivery is often necessary depending on stability and gestational age. Seizures or eclampsia: immediate administration of magnesium sulfate. Stabilization and urgent delivery if necessary. Timing depends on severity, maternal condition, and fetal well-being. Chronic or gestational hypertension: deliver at 37 to 39 weeks. Preeclampsia without severe features, 37 weeks. Severe preeclampsia, 34 weeks or earlier if maternal or fetal instability. Continue to monitor blood pressure. Some women will continue to require antihypertensive therapy. Risk of long-term hypertension and cardiovascular disease is increased. Long-term follow-up is essential. In conclusion, hypertension in pregnancy requires early diagnosis, careful monitoring, and timely management. With proper care, most women and their babies can achieve excellent outcomes. Thank you for your attention.